Good morning again. I will start and then Dr. Sano will take over. And I will present a video for an interesting case where aortic left ventricular tunnel with ascending aortic aneurysm and repair and aortic valve repair has been done. I have nothing to disclose. Aorta LV tunnel is an extremely rare congenital anomaly. It's seen in 1 in 1,000 infants born with congenital heart disease. It's characterized by an abnormal direct paravalvular endothelialized communication between the ascending aorta and the left ventricle. Sunji, you will follow after me. Hemodynamics equivalent to severe aortic regurgitation with subsequent aneurysmal dilatation of left ventricular failure. Interestingly, most of the time, these patients might present with right ventricular outflow of tract obstruction due to compression from the tunnel on the right ventricular outflow of tract. And surgical closure recommended at the time of diagnosis, including symptomatic patients. This is again a very rare abnormality, and this is one of the largest series from Boston Children's, 35-year experience with aorta LV tunnel. They have 11 patients between 1963 to 2000 to over 40-year period. Only 11 patients were seen in a tertiary referral center, and most of the time tunnels were closed with direct suture at aortic end. And I'm not sure direct suturing works always, and sometimes it might be problematic, and it's better to close with a patch and placate in the ascending aorta. And I will present an interesting case. I don't think this combination has been reported previously. This is an 18-month-old, 7.2 kilogram baby girl, and the original referral diagnosis with is VSD. Echocardiogram showed aortic LV tunnel with severe aortic regurgitation, aneurysmatic dilatation of the aortic root and ascending aorta, a hypoplastic left aortic cusp with restricted mobility, severely dilated left ventricular and depressed left ventricular function with ejection fraction 25%. Left ventricular diastolic dimension was 63 at that time. And do you have the pointer? This is the CT showing the aortic LV tunnel. Anyway, here is the 3D reconstruction. 3D reconstruction showing the dilated ascending aorta and then aorta LV tunnel. As you see, this is the area of right ventricular outflow tract, and this has potential to compress. And differential diagnosis, and sometimes it's easy to mix it with sinus or Valsalva aneurysm. The major point is on aorta LV tunnel, opening of the tunnel is above the sinotubular junction. If it's below the sinotubular junction, it's most of the time a ruptured sinus or Valsalva aneurysm. And most of the time it is from the right sinus. And again, this is the patient, and look at the dilated ascending aorta. Aortic cannulation has been done. Bilateral cable cannula, and aorta is circumferentially dissected, and then an aortotomy is made. Here's the aortic valve, right cusp, non-coronary cusp, a very small left cusp here. Here's the right coronary orifice. And here is the open of the LV tunnel. And cardioplegia going through the right coronary orifice there. And tunnel is going directly to the left ventricle. Here, you see the tip of the dissector out there. Resecting the ascending aorta. Here is the left coronary orifice. There. Again, very small aortic left cusp. Here's the coronary orifice. This is resected. This is the orifice to the LV cavity. Dacron patch has been tailored and continuously sutured in place. Sometimes it is important to placate the tunnel inside, because even with the closure here, it might compress the outflow tract, and it might be closed through the aortotomy here on the ventricular side. Here is the aortic cusp now. Left one, and there are stretch tears. I decided to create a bicuspid aortic valve and closing the stretch here, stretched fenestrations. Again, left and right coronary cusps are conjoined. Long-term aortic regurgitation is a problem on these patients, and it is important to follow these patients with LV aortic tunnel for aortic regurgitation. This patient is now over 5 years with no aortic regurgitation, and the LV regressed to normal sizes. Here is the conjoined cusps. One more stitch here if we need it. This was a hypoplastic left cusp. It's the aortic orifice. Size in and closing the aorta now, making a plication and reduction aortoplasty on the proximal part. Competent valve. Here's the graft to replace the ascending aorta. Testing the valve with cardioplegia. And distal anastomosis. Cross clamp removed while the standard aortic graft. Another plication sutures. Again, aortic LV tunnel is a very rare congenital abnormality, and the repair is needed. This case is unique because there was an ascending aortic aneurysm with regard to the size of the baby, and aortic valve repair was done by bicuspidization of the hypoplastic leaflet, and now 5 years postoperatively there is only trivial aortic regurgitation. Thank you. Any questions?
Very nice case.
Why?
The ascending aorta was dilated in this patient. Did he have some aortopathy or something?
You know, we send it to the pathology, and that's usual fragmentation of the collagen leaflets, but there's no, the distal ascending, distal arch and descending aorta was normal size.
Yeah, that's what. So something is happening only to the ascending aorta.
And we are following it with no problems so far.
I remember
probably an aortopathy.
Yeah. And the aortic valve is tricuspid, so then it rules out a bicuspid ascending aorta, which is getting dilated.
It was just tricuspid. Bicuspid. It was very kind of bicuspid valve. It was very hypoplastic left coronary.
Because in the bicuspid valve, the abnormalities of the aorta are well known.
Yeah.
I remember doing one such case in which the left coronary artery arose from the LV side of the tunnel. So we had the orifice of the tunnel, and then at the distal end of the opening, the left coronary artery was there. So we had to put a patch in such a way that the left coronary was not obstructed. So the patch had to be inside. So that can be very difficult to do, but then you can't do a continuous run. You have to do an interrupted suture. But that patient was around 10 kilograms or so, and it's been now more than 11 years. So far we have not run into any problem. Luckily the aortic valve was normal. So that was a good thing. But it's a very, very nice case.
Thank you. Our next speaker is Dr. Sano. Sunji, what are you presenting now? We don't know your talks. Which one?
Next one is the aortic valve surgery. So aortic valve disease in children is either aortic stenosis, the congenital rheumatic, or the aortic regurgitation. The congenital aortic stenosis or the critical AS is the many of the patients they have like the bicuspid rather than tricuspid, tri-leaflet, and I know the Asian countries there's still lots of like a rheumatic disease, which is very very rare in Japan and the United States now. The congenital bicuspid the valve is shown. The 70–80% of the congenital bicuspid valve is like this one. The surgical option in small infant, small children is the valve repair, of course, the first choice. And if we cannot repair the valve, then the next choice is a valve replacement, either mechanical valve, bioprosthetic valve, homograft, pulmonary autograft, so-called loss operation, and now the autograft pericardium with Ozaki. The aortic valve repair, this is the aortic valve anatomy and the regions classification. This is the paper, 264 patients, freedom from recurrent aortic regurgitation, and then freedom from aortic valve reoperation at 5 years, 88% and 92%, which is not very bad, but it's not excellent. There's lots of technique to repair the valve, subcommissural annuloplasty. Now there's a new the tool of this one, the central free margin plication, and resuspension with using PTFE sutures. The other one is the aortic valve repair and the central plication technique. This is a paper from Chicago. The freedom from reoperation is 18 years is only 50%. So this is a paper from the Boston Children's, 81 patients less than 19 years. They have lots of different techniques to repair the valve. But then the freedom from any aortic valve intervention and from aortic valve replacement is at 5 years, 63%, at 7.5 years, 41%. And the new technique is the tricuspidization from a bicuspid valve, and either using the cuspid extension technique or not. This is the paper published from Royal Children in Melbourne. They have very aggressively tried to repair these valve. Although the long-term results of this new technique is much better than the previous technique, but it's not satisfactory. Then if we cannot repair the valve, then the next option is the valve replacement. The most standard technique of valve replacement is either mechanical bioprosthesis, especially in adult population, but it's a need more than 80 millimeter size valve if you try to avoid reoperation, and they may need annular, enlargement. Everyone knows in children an early degeneration of bioprocesses, And many surgeons try to avoid bioprocess in small children or teenage. The high frequency of late complication, although high frequency of late complication in the mechanical valve too. The other option is a homograft. The homograft as a thromboembolism is almost zero, no anticoagulation medication, and the freedom from thromboembolism at 10 years, almost 100%. But the 7-year reoperation free survival is only 73%, and no growth potential. So it's not ideal graft to small children. The other option is the loss procedure. The advantage of loss procedure is the most commonly used in neonatal small infant. The absence of thromboembolism and low incident endocarditis, and long-term durability, but no one knows more than the problem may occur after 5 to 10 years. The patient have a potential growth potential, or this is only due to the dilatation of the annulus, and also the loss. The disadvantage of a loss procedure is create two-valve disease. So the freedom from reoperation from the pulmonary autograft, 2 years is excellent, and the 99%, but then in 8 years' time, 90% down to 90%, and then more than 10 years down more. So the national practice pattern and early outcome and aortic valve replacement in children and teenage in North America. The STS Congenital Heart Surgeon Database, the all aortic valve replacement, either the mechanical valve prosthesis loss on others, and in the age 1 to 18 years. 3,446 operations. The less than 12 years in half, more than 12 years and almost half. The valve used, the majority, or the most common procedure is a loss, 64% in children and 37% in teenage. The mechanical valve in the children in 19%, and then in teenage group in 35%. Valve protest 8 on 20, and the homograft is 9% in children and 7% in teenage. That is the real data in North America. The other is the concomitant operation is a corner operation because of the aneurysm is small. So the 15% of these patients had a corner to enlarge, and the mitral operation, the aortic arch and the coax, and on 2%. So in the children, the 64% loss, and then the mechanical valve, and then the either by processes or loss or homograft is similar. In the teenage, the more children they have a mechanical valve, and also the bioprocesses, and the loss is much less. And so in the left hand side is children. Is more commonly used technique is a loss, and then the right hand side is the teenage group, and the loss is getting less, and the mechanical valve is increasing. According to the sex, the girls, of course, is preferred not to have an anticoagulation therapy. So either the loss or the bioprosthesis. According to the number of experience or cases, then the high volume centers prefer to do loss, and the low volume center prefer to do the valve replacement. The early outcome by valve type is the early and mortality is very low, but it's except for the homograft replacement. So if all these procedures, either valve repair or the loss or others failed, the standard operation is the mechanical valve or the bioprosthetic valve. This is the paper of 160 children experienced. Of course, the mechanical valve have a problem, and especially if you use the small children. Out of 160 patients, the 24 the patient died without second AVR, and then also the 3 days after the second an AVR, and then 3 more late days after the and the late follow-up. So the mechanical valve or the bioprosthetic valve replacement is not ideal things. But this is the paper from the Boston Children's in the 121 and a patient. Valve implanted, mostly the St. Jude and Onyx valve. And if the aneurysm is very small, they use the carbomedics in 3 patients with a 16 millimeter size. So the follow-up on the median 5 years, the early death 5 and the late death 14. The survival in 1 year is not 90%, but in 10 years is 81%. The freedom from valve reoperation, because the carbomedics, all the carbomedics valve need reoperation because of the only 16 millimeter size, which is small. And this is the 16 to 17 is the carbomedics, and the need reoperation. And then also the small aortic annulus. The surgical technique is enlarge the annulus. The technique is anterior annular enlargement. The technique is the corner or Rastan procedure or Ross corner operation. If you prefer to do, if you can do an enlarge with only the posterior annular enlargement, Nix or Manugian technique. So the summary is the loss chosen most frequently in children and teen age people, especially the children. There is no option of other valve. Teen girls are more likely to receive autograft compared to teen boys, although the early outcome are similar across the valve types. The homograft have a higher morbidity and mortality, and the valve choice was related to the aortic valve surgical volume in each centers. The high volume center prefer to do loss, and the low volume centers prefer to do either mechanical valve replacement or the bioprosthetic valve. So even if we do choose all these procedures, the long-term freedom from reoperation survival is not satisfactory. So is there any better aortic valve surgery in children? And I hope the Ozaki procedure may be a better choice for the children and teenage population. Thank you very much.
Dr. Talbot?
Thank you for a nice presentation. We have a large experience with the Ross operation. Now the problem which I have observed is the rheumatic heart disease is very common in India. So we have a lot of patients of around 15 years or so who have the rheumatic activity, the aortic valves are bad, you cannot repair them, so they require replacement. And many of them have the mitral disease also. So when we were very aggressive in the 90s, so we used to do the Ross procedure and the mitral valve repair. But soon we found, within 2 to 3 years, that the autograft, it got infected by the rheumatic disease. So therefore we stopped doing the Ross procedure in young rheumatics. And we published that also. So then we went over to the homograft. And we started doing the homograft, but because the reoperation might be difficult in these children down the line, once the homograft calcifies. So we started using the homograft in the scalp subcoronary technique, rather than the root replacement technique. So currently our procedure of choice is, if young rheumatics come to use, especially if they have mitral disease, then to use a homograft aortic with the mitral valve repair when you don't want to put a mechanical valve. Obviously these days the mechanical valves are very good, especially the Onyx valve, in which you do not require much anticoagulation. But we would prefer to use a homograft aortic and the mitral repair. The other thing which we found was that if you put the homograft in the aortic position, the aortic homograft works better than the pulmonary homograft. So that also we published, because if you see the homografts, there is not much difference, and the wall of the pulmonary artery homograft is thinner as compared to the aortic homograft. But even when you do a scalp subcoronary, you put it in the aortic position, it tends to fail very early as compared to the aortic valve. So I think the process of the practice of the aortic valve substitute for these patients continues to evolve, and hopefully the Ozaki procedure will leave us with a lot of options. Thank you.
So I wanted to have a question to you.
Yeah.
If the aortic aneurysm is small,
Yeah.
do you enlarge the aneurysm and then put a homograft in sub?
Yes.
Right.
We do, but the enlargement would not be an extensive enlargement like a cono procedure. We would often go on into one of the sinuses. The good thing about the rheumatic heart disease is that the annulus are not very small, like as compared to the other lesions of the aortic valve. The rheumatic annuluses are typically, they would be 15 or 17 valve they would take. So just go down into the non-coronary sinus. Many times put instead of closing the aorta directly, use a patch to close the aorta, and that takes care of it. The other alternative would be to do the replacement of the aortic valve by a root replacement. Then you eliminate the need for enlarging the aorta too much. But so far we do the scalp subcoronary technique in such a way that when these patients come for the reoperation, you just open the aorta and the valve looks like what it used to look the first time. So just take out the valve and put a mechanical valve. So that is our current policy.
What kind of homograft do you use?
Aortic.
Fresh or cryo?
Cryo.
Cryo?
In fact, we had this study also in which we had the antibiotic treated homografts with the cryo homografts, and found that the results were better with the cryo homografts. The 1 or 2 times we have done something we were lucky that there was a heart transplant going on in one of the adjacent rooms, and we had a patient who required an aortic valve replacement. So what we did was the donor heart was put into the recipient, and when the recipient heart was taken, the aortic valve was harvested in the operating room itself and transported to the other room and used to replace. But that is just 3 or 4 cases. But in rare circumstances, and if you're lucky, that may be an option.
Any other questions? Dr. Sano, thank you.
Yeah. Next one is me too.
Do you want to do the next one?
I think yeah.
Yeah, please.
So I talked to the last slide at the Ozaki procedure, and maybe the next option. So the 12 years experience of reconstruction aortic valve using autologous pericardium, so-called Ozaki technique. These one I already talked, so just skip all these things. Just concentrate on Ozaki. So the aortic valve reconstruction using self-developed aortic valve plasticist and aortic valve disease is that they published from Dr. Ozaki in Japan. The aortic valve plasty using aortic pericardium and aortic stenosis 65 patients and the 23 patients with the aortic regurgitation. And then the next, the published paper in Circulation Journal is the 416 and the patient until 2013. The hypothesis is Ozaki is in systole, the aortic aneurysm start to dilate, the valve cusp start to open, and blood flow from the LV then open the aortic valve the cusp fully, so that like a natural normal motion of the aortic aneurysm. But once you do the valve replacement, the normal aortic aneurysm movement is destroyed. So all the fixed, no aneurysm movement at all. The Ozaki procedures is the only change the cusp, so the maintain the normal annular movement, and even after the Ozaki, which is so that the different like a stress to the aortic cusp might be different from usual procedure. So the advantage of Ozaki procedure is maintaining single valve disease and applicable with any valve anatomy. Of course, the most easiest anatomy is a tricuspid, but it's applicable to bicuspid or unicuspid valve. And also the very good indication of the endocarditis. And also now recently the Boston children people use this technique to repair of truncus arteriosus. This is the instrument set for the Ozaki, the sizers, and then the most important part of the procedure is the sizing, actual sizing of the aneurysm. If you wonder the 23 or 25, then better to you choose the bigger size. Once you sizing, then trimming the cusp already preserved with the glutaraldehydes, and the Ozaki himself recommended 10 minutes of preservation, but I prefer to preserve the 5 minutes in the children. 10 minutes is probably more to the bigger size cusp or the older adult. It's the short video. I just skip this one. So they change the three cusps, and then they fix the commissures, which is a little bit different technique. from his original technique, and he didn't put an additional stitch to fix the cusp. And now he changed because it's more stable, and then the reoperation is much less. Then after repair, the shape of the three cusps is like, and he called like a Mercedes shape. And then the recent paper from him is the midterm outcome in 850 patient. So this is the same template, and take the pericardium, and the sizing. So the sizing of each the commissures. So this is the diameter changes of the aortic annulus by TEE. The left-hand side is like a normal annular movement. After usual like aortic valve replacement, the annulus movement is disappeared and then become flat. But it's, after the Ozaki procedures, the annulus movement is near normal. Because he is the adult surgeon, so the most of the patient is adult, and the only 40 or 50 patient are teenage. So the age population is mostly 70s, 80s, and very few patients are teenage. He never did the Ozaki procedure less than 10 years of age. So the isolated Ozaki procedure, and just over half of the patient, some of the patients need the maze, and the cabbage and the mitral valve repair and tricuspid valve repair, and then the 21 patient had need lute replacement. So the result is the cross-clamp time, cardiopulmonary bypass time, is a little bit longer than the usual aortic valve replacement, but it's not very much long. The operation. 13 patients, the almost all 13 patients out of 15. So the mostly due to the infective endocarditis, and the one the tear of the thread, and the one also tear. These are from his our experience. So this is just a little bit busy slide, but the reoperation, all the reoperation cases, and mostly the IE. And then the post-operative pressure gradient across the neocusp is a little bit high because the cusp is glutathione treated and a little bit stiff, but it's they become more flexible, and the pressure gradient come down. That is the one of the reasons why I do not want to preserve the valve in 10 minutes, and because the children's the cusp is smaller. And if you do 10 minutes of preservation, from our experience, the pressure gradient is really high, like a 10-20 millimeter mercury or more. Since I changed to the 5 minutes of preservation, the pressure gradient is much less from the beginning. Well, the overall survival from his series is 86%, because most of the patients have 70s, 80s of age. the freedom from reoperation is almost 96%. As I told you, the majority of reoperation is due to infective endocarditis. So the question is whether the patient better to have the antibiotic therapy for a little bit long time or no need. Is there any difference? So his experience is quite huge. He do more than 80 cases annually. So this is his modified technique of putting an additional stitch to the cusp to fix it, to stabilize the cusp. And also he now try to do aggressively repair the bicuspid and the unicuspid valve, which is a little bit tricky and difficult, but it's you always think of the coronaries. So the indication of the Ozaki is the aortic stenosis and insufficiency, the both or the aortic anatomy is not the contraindication. You can do Ozaki and bicuspid valve or unicuspid valve, and also the even truncal valve. I forgot to add some of the result. Oh yeah. And now the very much recent result from the Boston Children's is they started the Ozaki procedure in August 2015. After the Ozaki went to Boston to teach them how to do Ozaki, and then just only in the 4 years they did 90 patients, and so the age is the smallest one is less than 1 year, and then the mean age is 12. The weight, average weight is 44. The smallest one is 5.2 kilograms. The valve anatomy is the bicuspid, and the sum of the patient and the 16 patient had a unicuspid valve, but the majority is half, almost half is the trileaflet, tricuspid. The diagnosis is the 4 patient truncus and the 5 patient endocarditis, and the 5 patient the after arterial switch. Because they have lots of reoperation, the glutathione treated the pericardium was only 1/3 of the patient. To redo cases, they prefer to use photofix, and then only 2 patients had a cardiac cell bovine pericardium. The leaflet size, the smallest leaflet size is 13. And the result is although the follow-up time is short, they lost 2 patients as a late death because of many patients had a redo and complex anatomy. Quite often they need to enlarge the sinus and root enlargement, ascending out or the reduction or other concomitant procedures. Then the freedom from more than moderate aortic stenosis at 1 year is 100%, and the freedom from moderate and more than moderate aortic regurgitation at 1 year is 97%. And the 5 patients had a moderate aortic regurgitation, aortic stenosis. So they think the risk factor of reoperation after the Ozaki is no relation to the body weight and preoperative aortic stenosis or aortic incompetence, and the reflux materials, anticoagulation is no different. So the message is the Ozaki procedure has excellent mid-long-term result in adult population. But personal experience of Professor Ozaki is now more than 1,100 cases during 12 years. And the freedom from reoperation in 12 years is 95.8%. And he did 20 pediatric patients in 9 years. And in a Japanese database of Ozaki is almost like a 70 pediatric population. And the Boston Children's Hospital experience was 57 pediatric population. In autologous they prefer to use autologous pericardium if the child is the first operation case. If it's a redo case, they prefer to use the photofix valve cusp. And then the short-term result in 2 years is excellent. And then the different from other technique is aneurysm with growth. So they also did clinical research. If you use the 50 millimeter cusp, that cusp, even if the aneurysm dilate, that cusp maintain the valve coaptation with 2 sizes bigger. So that means if you use the 50 millimeters neo-aortic cusp, that lasts until 19. So the 1 size means bigger is 2 millimeters, so 17, 19. So if the aneurysm dilated 21, they start leaking from central. Yes, and of course the advantage is no need of anticoagulation. Thank you very much for your attention.
Sunjay, with regard to the photopix, I don't know if you use photopix for Ozaki, but I don't feel comfortable with photopix. It's much more stiffer than autologous pericardium. I always prefer to use autologous pericardium and slightly treat it like 5 minutes instead of using photopix. I don't know why their Boston's experience is different with autologous pericardium, but my personal preference would be going on with the autologous pericardium. The issue with the photopix,
if you do a redo case, what kind of material do you prefer to use? Photofix?
Redo is different. Redo is the only...
Cardiocell.
You have no chance. Redo, if you want to do Ozaki, it would be on a photopix. And cardiocell is terrible. The worst is cardiocell. You stay away from cardiocell for anything but photopix only option. But if patient has on pericardium, I would go with autologous pericardium.
Yeah, the Boston people said that if the patient is like the first operation, not redo case, they prefer to use the autologous pericardium. But if it's a redo case, they use the photopix. I never use the photopix to the Ozaki, but I don't know what it look like. But the Pedro, the Leonardo's comment is the photopix is much better than cardiocell, and then also in a very short follow-up, the result is very much similar to the autologous pericardium. So I don't know the midterm, long-term result.
I have no experience with PhotoFix. So at our place, the protocol is that if it's a redo, then you try to harvest the pericardium from the most lateral aspect, and you can still get some pericardium, which is as good as the treated pericardium. If it comes to treating the pericardium, as you correctly mentioned, we also treat for about 5 minutes in 0.625% glutathione, because that makes it just good to handle. And if you try to fix it for more time, then you risk the calcification of the cusps. The other thing which we have is that we have our own in-house valve bank. So in which we get the hearts. In India, we don't have the companies which are harvesting the homografts. So we have our own homograft valve bank and go to the mortuary and harvest the hearts and take the pericardium out. So always some homograft pericardium is available to us, which is antibiotic fixed. So we can peel off all the fat from the homologous pericardium and use it for the Ozaki. And we found that the result was very good. One question which I have for you is, I saw that there were 2 patients with truncus arteriosus. Now, how old were they? Were they adults or were they small kids?
7 months, 8 months.
Okay. Because if these patients were adults, the truncal root would be grossly dilated, and it's likely that one of the sinuses is deformed. So it might argue for a valve replacement in the older kids. Obviously, for the small kids, there is not an option. So were the sinuses of these patients equal? They had a quadricuspid valve, because I don't know how in a quadricuspid valve the Ozaki would fit in. But that is something which would be interesting to see.
No, I don't know the exact detail. They only they gave me the data.
Yeah. Because I don't know how in a quadricuspid, because bicuspid there are techniques, but quadricuspid valve there are no techniques. And many of the truncal valves are quadricuspid with asymmetric distribution of the sinuses and all that. So that would be interesting to know.
Thank you, Sunjay.
Thank you.
Our next speaker is Dr. Sakamoto, and he will be presenting Nikaidoh, Rastelli, and Arterial switch, which is probably one of the most complex and difficult cases in congenital cardiac surgery. And we would like to see your expertise, sir, Professor.
Thank you. Thank you very much for the introduction. So from last night, I did make this slide. So, yeah, possible. Oh, yeah, it's okay. So anyway, so my duty is TGA, VSD, and LVOT. So, which procedure is preferred? That's my question. As you know well, so TGA group has 20% or around 20 to 30% had VSD, and LVOTO among the VSD 20%, and together with interventricular septum less than 1.0%. So LVOTO group has a very small group. And so those groups require the operation of Rastelli type procedure and others. And the history, this slide showed history of the surgical strategy for those patients with LVOTO. So originally, Rastelli procedure was the recommended procedure from 1969. After that, so Lev by LeConte recommended the Lev procedure, and from 1984, and another surgeon, Japanese surgeon, Dr. Yamagishi, Professor Yamagishi recommended to develop the new procedure of half-tan truncal stitch operation. And this slide shows outcomes of Rastelli, Lev, Nikaidoh procedure. So we have so many experience to use Rastelli procedure on those patients. However, originally or conventional Rastelli procedure had a problem on late LVOTO and RVOTO stenosis especially on condit. And LeConte maneuver, so Lev had a better result than Rastelli type procedure. And after that, so to make an improvement on those patients, so Dr. Nikaidoh developed the Nikaidoh operation with aortic translocation. Anyway, this slide shows all the procedures, Rastelli, with the patching to make LV aortic tunnel without resection of the coronal septum and valved conduit from the right ventricle to PA with usually the handmade valve and lev and mattress together with the modification of mattress and the resection of the coronal septum and rather straight patch from the on the ventricular septal defect together with without conduit, direct anosmosis here and patching. And the Nikaidoh half triangular stitch has aortic translocation like this. So LV is connecting to the aorta without kinking root, together with the conduit and others. So this slide shows long or curved LV aortic tract on Rastelli type procedure, lev, rather straight, but there is some obstacle between so LV to aorta. And aortic translocation has direct and straight route from the left ventricle to aorta. And the RVPA route, Rastelli, conduit long way with the artificial or handmade valve usually. Lev, no valves usually, no valve, together with the anterior patching. And Rastelli type procedure has sometimes the conduit, sometimes the natural PA valve, together with not aortic translocation, with PA translocation. And as you know well, recently, several surgeons recommended a modified Rastelli procedure, together with the resection of outer septum like a lev, and more reliable valved conduit like EPTFE, graft with a meticulous handmade valve. That modified Rastelli procedure have a better result than previous historical Rastelli procedure and almost same lev or others. Anyway, Dr. Houdekamp in Holland reported the optimal procedure, that consideration from the anatomical study. So LVOTO, LVOTO, LVOTO. And 60% are candidate for arterial stitch operation. And this group, 21, half of them, and the candidate for Rastelli, lev, Nikaidoh type procedure. And he study about the feasibility or reasonability to use which procedure from of Rastelli, lev, Nikaidoh. Nikaidoh type procedure is most cases are candidate for the procedure with aortic translocation. Anyways, so I show my video. So not my technique, but modified Nikaidoh procedure with double root translocation with pivot rotation technique. So 1 year, 7 years old, 1 year, 7 months old, 10 kilogram. So DRV or TG and VSD, borderline. And conoventricular VSD, so-called remote type. Moderate LVOT obstruction, bicuspid pulmonary stenosis, 7.4 millimeter, minus 0.4, 4.4 Z value. And I open the main pier. And after that, dissects all around the PA valves. On this patient, I try to use the PA translocation. So I call this procedure double root translocation with natural valves. You can see the valve, pulmonary valve. Oh, this is the area of the connection between the pulmonary valve and the mitral valve. Yeah. So this PA is resected together with native pulmonary valve and open the ascending aorta and check the coronary position. And cut out the anterior coronary artery. Anyway, now I open the right ventricular side to take careful and meticulous procedure to avoid the aortic valve. You can see the aortic valve inside. That's one. I didn't reject the aortic valve. I cut around the aortic valve around 2/3 or 3/4, and open to the rejected PA area, and cut again, and this aortic valve is rotated and moved on the rejected PA areas. Anyway, after that, close the maker LV aorta root, LV aorta direct and straight root. And after that, aorta. And now, cut open the main PA to make valvuloplasty on pulmonary valve, like a tetrahedral follow. And reconstruct the main PA size using the autologous pericardium. And finally, reconstruct that. Like that. Anyway, long operation. 1 year later, the LVography showed straight LV aorta root without no regurgitation. This slide was the previous slide 3 or 4 years ago. So now I had around 10 to more consecutive cases, but I didn't have a slide. 6 cases. Anyway, after this procedure, body weight is from the 7.5 to 14.6 kilogram, and the coronary pattern is showing. And the pulmonary valve size like that, from 6 to 12.9. And I did make a double root translocation in 3. And the complication is complete AV block. This one is a hemibuster, and on the patient with CHD. That's the reason why, maybe. And the hospital stays like that. AR discharge, no. LVOT discharge, no. However, later, AR, one patient had mild. LVOT from 2.5 to 3.7. PR is no, 3, and with moderate 2. Together with anterior patching of the LVOT. This one is, these 3 patients had native pulmonary valve because depending on the double root translocation with native pulmonary valve. Anyway, comment on Nikaidoh type procedure. Early and mid-term result of aortic root translocation using pivot rotation, not my technique, but pivot rotation are satisfactory or acceptable. And this procedure will be a good surgical option for selected cases with complex form of TGA. Long-term benefits need to be evaluated with a longer follow-up. Anyway, these procedures have a risk of LVOT, of course, and sometimes the LVOT, this group, even on the patient with modified Rastelli and LF and AR, because too much operation on the aortic valve, around the aortic valve, translocation. Anyway, 60% of this group are candidates for arterial switch. Dr. Hardokan reported it. I believe it. And so this video, this slide shows our result of the arterial switch operation. Not so large experience, but as you know well, arterial switch operation is standardized and reliable procedure. So we have to consider which is better, arterial switch operation for those patients with LVOT or not. Arterial switch operation, near anatomical repair, but we have to make resection of LVOT. And pulmonary valve repair sometimes for the patient with bicuspid aortic valve and the second and the adhesion of the leaflet. So, key point of decision making, which is better? Feasibility to make arterial switch operation. And the timing, that's a new information and the rate outcomes. As you know well, this patient with LVOT, fibrous ridge and accessory tricuspid tissue prolapse through VSD, it's okay to make arterial switch operation without big problems. However, abnormal mitral attachment obstructing LVOT or overriding others, if we, of course, we can cut or reject the tissue. However, control the mitral function is not so easy to do. So, which is better? Usually it's not feasible. We decided. Anyway, this is information from the Australia, and 26 patients with this condition. 70 had abnormal LVOT, and 9 had abnormal pulmonary vein, including bicuspid, 2 AATS, and no rate. However, 2 patients had reoperation on LVOT, and 1 patient had reoperation for neo-aortic regurgitation. And another information coming from the Boston, 88 patient, huge experience, early this one. However, caution with multi-level obstruction, not only the LVOT, but also LVOT and others. And very interesting information are there. This is, what is this? What is this? Important information is this one, delayed repair group, not on neonate or early infant, late Rastelli or translocation type procedure. At that time, after postnatal, initial postnatal diagnosis, at the initial postnatal diagnosis, the size of the annulus of the pulmonary vein here, and at the timing to make a repair, not grow well. However, if the patient had neonatal arterial rupture operation for the patient with LVOT or slightly problematic pulmonary vein, at the time, the pulmonary valve annular size grew well. So the patient is not same. So it is not so easy to understand which is better. However, so on the patient with LVOT, the slight pulmonary valve problem, maybe pulmonary valve can grow after arterial suture operation. And those patients have a difficulty to grow without arterial suture operation, waiting during the waiting time. I don't know exactly, but we have to check this information. And Kalfa reported the result on those patients, 55, and LVOT procedure 23. Aggressive intervention to the LVOT, and 6 early deaths, 2 LVOT-related deaths, and no rate deaths. However, the operation 3 on LVOT gradients, 4 LVOT reoperation, 7 neo-aortic regurgitation, big percentage. Anyway, from the Kalfa's data, predictor of LVOT is related to PVZ score, less than minus 1.7, and mitral valve abnormalities, and predictor of aortic regurgitation after this procedure, Lesion LVOT. Yeah, seem important. However, at the same time, this one, LVOT intervention at arterial suture operation. So not so easy to reject the LVOT through small or through pulmonary valve because of the size and the reflex condition, maybe. Anyway, so pulmonary valve Z-score over minus 1.8 have a good result, even using this procedure. However, less than 1.8 have a difficulty to get a reasonable result. Take-home message. On the patient with TG-VSD and LVOT, more than half ones have a possibility to do arterial suture operation together with or without pulmonary valve intervention. Timing to make the arterial suture operation and simultaneous LVOT intervention for this group may be related the rate result is better rate result, especially on original PV growth and the LVOT. Rastelli type procedure on this group have been improved reasonably. However, some of the patients require Nikaidoh type procedure with aortic translocation. It is not clear both which is better for this group among arterial suture operation, modified Rastelli type 1s, and Nikaidoh type 1, and decision-making lying of the size of the pulmonary valve annulus and LVOT condition. So today's target is which is preferable, which procedure preferable, but I cannot decide which one is better. Thank you very much for information, attention.
Thank you, Dr. Sakamoto. Great talk on this very difficult topic. And with your rotation procedure, when do you want to operate these patients? What is the good time to operate?
Yeah, so why? So I did make this, I choose this procedure together with pivot rotation. Yeah, so together with the pivot rotation, we don't need 2 coronary translocation. And to use this pivot type rotation, I checked before operation the running course of the coronary artery, especially the posterior side. If the posterior side coronary artery has a better running course from the aortic wall to distal, 1 centimeter distal side are straight, at the time pivot rotation, those patients has a better candidate to use pivot rotation. And I did use this procedure for some patient. I sometimes do a usual Nikaidoh type procedure or half-turned truncular sage. That's also good. However, two coronary translocation, and sometimes we have to make some modification on the form of the ascending aorta to make a better coronary.
What age do you want to operate on this prefer to operate on this age? Yeah.
Age, yeah, around 1 year. maybe because the feasibility and choice of the RVPA conduit. So around 10 kilogram, we can choose the more than 16 millimeter RVPA conduit in size. 16 millimeter is reasonable to use. I think so.
Dr. Thaler?
Thank you.
All the three operations, like the Nikaidoh, then the pulmonary root transfer, the double root transfer, and the half-tone truncal switch. And as you correctly mentioned, we want an age more than 1 year and the weight around 10 kg or so. So if a patient requires intervention before that, we would do a systemic to pulmonary artery shunt, and that will be from thoracotomy.
Yeah, you're right.
So that the at reoperation is not very difficult. So that is one thing. Then second thing is the Nikaidoh. Like I think you are more fond of harvesting the coronary buttons, and that makes life easier. So, but we try not to harvest the coronary artery buttons, and sometimes we take off the root without actually arresting the heart. So without arresting the heart. So
I did not have an experience.
So the coronaries are getting perfused. You can cut down your cross clamp time, and it becomes better. Then third is we have almost now not been doing the Rastelli. So as an alternative to the Rastelli, we go for the pulmonary root translocation. The only problem with the pulmonary root translocation would be if the aorta and the pulmonary artery posterior, anteroposterior relation.
You're right.
Because then your difficulty having the pulmonary artery and going and setting up there.
Yeah, you're right.
Yeah. The other thing which we have realized, which is a word of caution, is the area from the while arresting the pulmonary root, you can damage the mitral valve. So what we do is we first make a vertical incision in the main pulmonary artery. Put a right angle on the other side and see where the mitral valve is. And the other problem which we faced with this operation in the beginning was the area from where we have taken the pulmonary root. So that used to bleed a lot. And then we have the circumflex and the left main just onto your left. So if you try to close the air directly or something, it's very possible that you damage the coronary. So we started, before we actually proceed with the operation further, we will close that area with a glutaldehyde treated pericardial patch using a fine scissor suture. So because if you have bleeding later on, it is impossible to catch. Then the other modification which we made was when we were doing a double root transfer, and you have a ventriculotomy. So then, again, if you have a big patch onto it, which is directly going over the, RVOT, you will tend to have the bleeding from back. And if you have the bleeding from the back, there is no way you can control it. So what we started doing was close all of the area with the pericardial patch completely, then check for hemostasis, and then release the clamp, and then see the anastomose and everything, and then make a vertical opening in the pericardium, and then put the translunar patch on top of that. So you do have a patch behind, and you have a patch anterior. So that makes it much, much, much easier. So these are some of the tricks of the trade which we have learned from our experience. The good judgment comes from experience, and experience comes from bad judgment. So we have gradually moved along, and now the other thing which we have started doing is in patients with corrected TGA, for whom the option would be a standing Rastelli or one of the standing of pulmonary root translocation. We have been doing the standing and the double root. So that avoids, yes. So that avoids many of the problems of the. But obviously, if your pulmonary artery relationship and the aorta is anteroposterior, and your coronary anatomy is not favorable, you are pushed towards a single ventricle. and you end up doing the gland.
Of
I think
course.
that is one of the
Of
reasons
course.
again.
Some patients have, so
that
it's a
is-
candidate.
Yeah. So that is one of the reasons why you postpone this. One of the reasons again which you might want to postpone this operation beyond 10 kg. Because if the baby is small, let's say he's 2 or 3 months, and you're pushed towards a single ventricle, it's not a good thing to have. So,
Yeah, of course.
more than 10 kg is something which we have also practiced.
Yeah,
Thank
of
you.
course. So maybe so the patient with DLV and some conus under the pulmonary valve is the target candidate to make pulmonary valve
Yes,
translocation.
you can resect the suborn coronal septum and then do a pulmonary.
And so during the operation, together with watching from the pulmonary valve, at the same time, so we can see the mitral valve through aortomy.
Yes.
At that time, so we can see directly all the segment of the mitral valve, annulus and fibrous continuity and the pulmonary valve, and decided it. That's better. I think so.
The
Yeah.
other thing which I realize is the Rastelli operation has been condemned for a long time, that it produces aortic obstruction.
right.
But that is based on the paper from Boston, which was published more than 25 years ago. So now, from that onwards, people have realized that
Less cardiac arrest time.
less of the and one of the contributors in those original papers, they never used to resect the subaortic conus.
Yes,
So
you're
now,
right.
now the people have started resecting the subaortic conus, and that has led to a reduction in the LVOT.
Yeah, you're
all
right.
said and done, if you can get a pulmonary route or a Rastelli, it is the most physiological operation to have, because
Yes, you're right.
it leaves you from a lot of problems. Because all said and done, the pulmonary route translocation is also not a benign operation. You can end up damaging the mitral valve. You can have the this immediate pulmonary irritation. And Nikaidoh, if you go, the slightest mistake, you can damage the coronary arteries, and the aortic valve tends to become regurgitant, and the bleeding from the back is very difficult to handle. So it's better to, like, we will always go for prepared for a switch. And if I find that the aortic valve commissures are fused, better to do a small commissurotomy and try and enlarge the LVOT. Because many times the LVOT is dynamic. So unless you have the LVOT obstruction which is fixed, and that time you would push to do a Nikaidoh. Otherwise, go switch and go home.
Thank you.
anyway.
Dr. We have to conclude, and then
Thank you.
we can continue discussion. And we'll come back at 1 o'clock for the next session. There are a few good video movies. Thank you for joining us.